If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we're going to review the draft NICE guideline on type 2 diabetes, focusing on the main changes as applied to 7 specific groups of patients. In the previous episode, we covered the first 3 groups, so today we will cover the rest. Right, let's jump into it. And as you know, the draft guideline is open for consultation until October, and the final guidance is due in February 2026. So let's not forget that it is only a draft, and we should not be making clinical decisions based on it yet. Today's episode is based on the visual summary created by NICE, and the link to it is in the episode description. The visual summary includes specific guidance for 7 different groups of patients. The group of patients with no relevant comorbidities, then obesity, frailty, CKD, heart failure, atherosclerotic cardiovascular disease, and early onset type 2 diabetes. And today we will look at the last 4 groups that we did not cover last time. So let's start with the CKD group. For people with type 2 diabetes and CKD, like for many of the other groups, the draft guideline recommends starting treatment with metformin plus an SGLT2 inhibitor. Because of licensing reasons, we are advised to choose either empagliflozin or dapagliflozin in this group. If metformin is contraindicated or not tolerated, the SGLT2 inhibitor can be offered on its own. Treatment will also depend on kidney function measured by eGFR. As we know, metformin is contraindicated if eGFR is less than 30, and given that SGLT2 efficacy decreases with advancing renal impairment, NICE recommends not using empagliflozin or dapagliflozin if eGFR is less than 20. Therefore, the first-line treatment on this basis is as follows. If eGFR is above 30, in principle, we will offer metformin plus dapagliflozin or empagliflozin. Although, if metformin is not tolerated, the SGLT2 inhibitor can be given by itself. If eGFR is between 20 and 30, we will offer either dapagliflozin or empagliflozin alone. And if eGFR is below 20, we will go for a DPP4 inhibitor in preference. If that is contraindicated or not tolerated, we will consider pioglitazone or insulin, given that sulfonylureas should not be given if the eGFR is below 30. This is because sulfonylureas accumulate in renal impairment and increase the hypoglycemia risk. If further glycemic lowering is needed after first-line treatment, we can use other options including DPP4 inhibitors, if not already used, sulfonylureas or insulin, depending on renal function and safety profile. How does this differ from previous guidance? Like in other groups, the big change here is the earlier, more proactive use of SGLT2 inhibitors specifically for renal protection, not just glucose lowering. Previously, SGLT2 inhibitors were used after metformin for people with established albuminuria or heart failure. Now, the draft guidance recognizes the trial evidence showing that, apart from the cardiovascular benefits, SGLT2 inhibitors also reduce progression of CKD, and this benefit occurs even if people with slightly reduced eGFR and independently of albuminuria. The slower progression of CKD is because SGLT2 inhibitors reduce albuminuria, intraglomerular pressure, and protect against hyperfiltration. Another nuance is that the draft now pushes dapagliflozin and empagliflozin explicitly into first-line therapy alongside metformin or alone if necessary, with thresholds set according to kidney function. And it also sets out clear sequence for treatment as eGFR declines, including when to use DPP4 inhibitors or move to insulin. What this means in practice is that we will need to check eGFR early and often, as it will determine the choice of treatment. Metformin and an SGLT2 inhibitor is the default down to eGFR 30. SGLT2 inhibitors alone is preferred when eGFR is between 20 and 30, and below 20 we will switch to a DPP4 inhibitor, and only after that will we consider pioglitazone or insulin if necessary. And practically, the bigger focus on protecting kidney function means that more patients will be started on dapagliflozin or empagliflozin earlier. So we will need to familiarize ourselves with renal thresholds and side effect monitoring. Now let's move to the heart failure group. For adults with type 2 diabetes and heart failure, NICE also recommends that the initial therapy should be metformin plus an SGLT2 inhibitor. If metformin is contraindicated or not tolerated, then an SGLT2 inhibitor alone is advised. If additional therapy is needed to help with weight management, then a GLP-1 receptor agonist, specifically subcutaneous semaglutide, can be considered provided there is no frailty and the patient has a preserved ejection fraction. After that, for further glycemic lowering, we can add a sulfonylurea or insulin. Remember that pioglitazone is contraindicated in heart failure. The difference with the old guideline is that the draft makes metformin and SGLT2 inhibitors the standard, aiming to get heart failure-related benefits earlier. As we know, trial data show that SGLT2 inhibitors reduce hospitalizations for heart failure, improve symptoms, slow progression, and improve cardiovascular mortality, independently of glycemic control. So using them early helps not just glucose but also cardiac outcomes. But another big change is that the draft also acknowledges that weight loss from GLP-1 receptor agonists can help reduce cardiac workload, reduce fluid overload, and improve quality of life in heart failure. Combining SGLT2 inhibitors with semaglutide in patients for whom weight is an issue is intended to deliver a dual benefit: cardiorenal protection and weight reduction. Previously, GLP-1 receptor agonists were less likely to be used early in heart failure, and semaglutide had stricter criteria. Now, semaglutide is explicitly considered earlier in heart failure, when weight benefit is also a goal. Any limitations? Well, semaglutide will be limited to patients with obesity, preserved ejection fraction, and no frailty. Frailty and ejection fraction matter because the benefits and risks of semaglutide vary. For example, the risk of dehydration and hypotension, depending on heart function and overall general state. What the changes mean in practice is that we will start more patients on both metformin and an SGLT2 inhibitor upfront. This also means that we will need to discuss SGLT2 inhibitor side effects like the risk of genital infections, volume depletion, sick day rules, and renal monitoring from the start. Patients will need assessment of heart failure subtype, especially ejection fraction, and frailty to decide who is eligible for early semaglutide. Monitoring will need to include not only HbA1c, but also cardiac function, renal function, and watch for adverse events. And finally, when adding semaglutide, the expectation would be that it's for weight benefit, so obesity must be present. Now let's look at the atherosclerotic cardiovascular disease group. For them, we will offer triple therapy with metformin plus an SGLT2 inhibitor and a GLP receptor agonist, semaglutide, for additional risk reduction and weight benefit. And it is worth mentioning that we should also consider semaglutide for any other group if at any stage atherosclerotic cardiovascular disease develops after treatment has already been started. If extra glycemic lowering is needed, we will add a sulfonylurea, pioglitazone, or insulin. As we know, we should not combine a GLP-1 receptor agonist and a DPP-4 inhibitor. But if a GLP-1 receptor agonist isn't appropriate, we will add a DPP-4 inhibitor instead, and before considering the other options of a sulfonylurea, pioglitazone, or insulin. This is different from the previous version because before, GLP-1 receptor agonists were not used for their cardiovascular benefit, but their use was rather tied to glycemic and BMI thresholds. The draft moves to routine early triple therapy with metformin, an SGLT2 inhibitor, and semaglutide when atherosclerotic cardiovascular disease is present or develops, bringing GLP-1 therapy forward in the pathway. This change is due to trial evidence showing that GLP-1 receptor agonists not only improve weight, blood pressure, and postprandial glycemia, but they also reduce atherosclerotic cardiovascular events, with semaglutide having one of the strongest evidence for this reduction within the class. Combining semaglutide with metformin and an SGLT2 inhibitor early is designed to achieve both cardiorenal benefits as well as a lower atherothrombotic risk. What it means in practice is that we will treat atherosclerotic cardiovascular disease earlier with SGLT2 inhibitors and semaglutide, and in principle we will continue these therapies long term, even if HbA1c or weight targets aren't fully met. Finally, let's move to the early onset type 2 diabetes group. For NICE, this group refers to type 2 diabetes diagnosed in people under the age of 40. First-line treatment here is also metformin plus an SGLT2 inhibitor like everybody else, but on top of that, the draft says that we should consider adding a GLP-1 receptor agonist early. If metformin is contraindicated or not tolerated, we will offer an SGLT2 inhibitor and still consider adding a GLP-1 receptor agonist. If more glycemic lowering is needed, the add-on choices are, again, a GLP-1 receptor agonist, if not already prescribed, a sulfonylurea, pioglitazone, or insulin. If a GLP-1 receptor agonist isn't appropriate, we will add a DPP-4 inhibitor instead, and before considering a sulfonylurea, pioglitazone, or insulin. This is different from previous guidance because before, early onset type 2 diabetes did not have its own explicit guidance. NICE is changing this because it has been shown that early onset type 2 diabetes carries disproportionately higher lifetime risk. In fact, large reviews show that early onset type 2 diabetes is linked to higher rates of complications and premature mortality at any given age compared with later onset disease, due to the additional years exposed to hyperglycemia, faster beta cell decline, and earlier cardiorenal and microvascular complications. So this is why NICE now favors earlier multi-mechanism therapy in this group, including GLP-1 receptor agonists for their cardiovascular benefits. What this means in practice is that we will start combination therapy sooner in the form of metformin and SGLT2 inhibitor, while proactively considering a GLP-1 receptor agonist early, in many cases resulting in early triple therapy. We will also need to assess tolerance and to monitor side effects as well as reviewing targets explicitly, while being aware that in early onset type 2 diabetes, continuing GLP-1 receptor agonists may be appropriate even when targets aren't met. So that is it, a review of the draft NICE guideline on type 2 diabetes, focusing on the visual summary. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.